Welcome everyone, and thank you for joining us today for Osteoporosis Canada's webinar, COVID-19 and Osteoporosis Treatments for Patients and Caregivers. My name is Kerry Grady Vincent, Senior Manager of Scientific and Clinical Programs at Osteoporosis Canada, and I will be your moderator today. This presentation will provide general information about treating osteoporosis. If you have questions about osteoporosis treatments, please consult a physician. Before we begin, please note, you can enter your questions into the question box to the right of your screen, or if you're watching this on an iPhone, there may be a question icon at the bottom of your screen. In addition to answering some of the questions that were submitted in advance, we will also attempt to answer those submitted during this live webinar within the time available. Please keep your questions relevant to the topic of COVID-19 and osteoporosis treatments for patients and caregivers. And remember, we cannot provide medical advice to specific individual questions. We are delighted today to have Dr. Aliya Khan as our presenter. Dr. Khan is a clinical professor of medicine, divisions of endocrinology and metabolism and geriatrics at McMaster University, and director of the Calcium Disorders Clinic at McMaster University Medical Center. She is also the director of the fellowship program in metabolic bone disease at McMaster University. She graduated from the University of Ottawa Medical School with honors. She trained in internal medicine, geriatric medicine, and endocrinology at the University of Toronto, and also completed a research fellowship in calcium and metabolic bone disorders at the University of Toronto. She has over 200 scientific publications on osteoporosis and parathyroid disease, as well as numerous book chapters and books. Dr. Khan is the chair of the Rapid Response Committee of Osteoporosis Canada, as well as the co-chair of the Knowledge Translation Committee of Osteoporosis Canada. She is a scientific advisor of the International Osteoporosis Foundation, and she's the Canadian ambassador for the American Society of Bone and Mineral Research. Dr. Khan has received numerous national and international awards, including the International Clinician Instructor of the Year 2011 Award by the International Society of Clinical Densitometry, the Queen's Diamond Jubilee Medal for 2012 for excellence in clinical care, research, and teaching, as well as the International Hypoparathyroidism Award for 2014, and the International Osteoporosis Foundation Award for Publishing Excellence in 2017. In 2019, she was recognized as being in the top 0.1% of the world's experts in hypoparathyroidism by ExpertScape. Please join me in welcoming Aliya.
Thank you so much, Kerry. That's very kind of you. And it really is my pleasure to speak to everybody today about how to diagnose and treat osteoporosis in a pandemic. And I'm going to go through my slides now. So this is, let me just make this presenter mode. Here we go. So I do have some disclosures, and I have received research funding from a number of the industry partners for the development of new molecules in the treatment of osteoporosis and parathyroid disease. And what we're going to talk about today is how do we evaluate osteoporosis, how do we treat osteoporosis, and what are important things for us to remember so that we can prevent COVID-19 while we're in the process of treating our osteoporosis. And so I wanted to begin by saying that osteoporosis is a condition where the internal structure of the skeleton is impaired. And you can see over here, we have a specimen of bone. This is a bone biopsy. And we're looking at the bone. We can see that the normal bone has a thick cortical shell. And then the inner part of the bone is like a honeycomb pattern. And this is someone with osteoporosis. So when you have osteoporosis, that means that your bone structure is not normal. The outer shell is thinner. The internal structure is not normal, and you will note that the trabeculae, or these bony struts, have lost their connectivity. So the connections have been lost, and this structure can fracture. So if you were to fall from standing height, you're walking on the street, and then you trip over the pavement. And you fall. So normally, if your structure is like this, your body will be able to absorb that shock. It will not result in a fracture. Our skeleton is designed not to break with a fall from standing height. But if your internal structure looks like this, it's going to crack because the cortical shell isn't thick enough to protect that bone from fracturing, and the internal trabecular microstructure is weak. They're not connected. It's like having the chairs on the legs on a chair. If they're not connected and a heavy person sits on it, it's going to give. So this trabecular structure is going to give with the force that is transmitted to the skeleton. And in fact, with osteoporosis, you can have fractures without any falls. Some of my patients, they've had spine fractures just with throwing a garbage bag or raising a window or carrying a baby. You can get rib fractures just by being hugged or coughing. And sometimes fractures can happen silently. And if you have a vertebral fracture, the vertebrae can crush downwards, and you can gradually develop a dowager's hump and lose height and not recognize that the height loss is because of spine fractures. So when I evaluate a patient, the first thing that we ask are, tell us about all the fractures that you've had from birth till now. And what did you break? How did you break? And we will grade all of those fractures. And our residents review everything. And we ask, okay, you broke your wrist. How did you break your wrist? If the patient says that they were on a ladder, or they were standing on the table changing the light bulb, then that is not a fall from standing height. So if you fall from a significant height, then there's more force applied to the bone, and the bone can break. Obviously, any bone can break. Even this bone can break. You know, if you're in a car accident and there's very severe amount of trauma applied to the bone, then yes, of course, you can have fractures. But people who have osteoporosis are more likely to have fractures with and without trauma. So if you're in a motor vehicle accident and you have a patient who's got osteoporosis and a patient who has normal bone density, the patient with osteoporosis is going to have more fractures in that car accident than the person who doesn't have osteoporosis. And so it's very important for us to gauge all of those fractures and confirm if the patient, number one, has osteoporosis and how significant is their fracture risk. And there are two ways that we diagnose osteoporosis. The first way is the clinical diagnosis of osteoporosis, and that's confirmed if you have a fracture with a fall from standing height. So if you fall from standing height, or you fall from the third step or lower running down the stairs, and if you fall from the third step or lower and you break something, then that is also considered a fragility fracture. Now, if you break something with a fall from standing height or running down the stairs from the third step or lower, that confirms that you have osteoporosis. And the sites that don't count are facial bones, hand bones, ankle fractures, and feet fractures, because these bones are small. And so if, for example, you have a stubbing injury for your toe, then that doesn't imply that your total body bone strength is impaired. It just means that in that small little bone, there was enough force applied to that bone that it fractured. But it doesn't mean that your total body bone strength is impaired. And we now say that ankle fractures are not considered fragility fractures. They happen to be more closely associated with body mass index than with bone density. And usually ankle fractures are seen in people who are heavier, and they may roll over their ankle and sustain an ankle fracture. Metatarsal fractures, we say, are not fragility fractures. But having said that, if someone has recurrent metatarsal fractures, we worry about rare bone diseases such as hypophosphatasia, where you may not be able to mineralize the skeleton because of accumulation of molecules that prevent mineralization of the bone. And so it's important for people who are having recurrent metatarsal fractures or having early tooth loss or significant muscle and joint pain to consider the possibility of a rare bone disease and discuss that with your doctor. So what does your doctor do? Well, they will take a very careful history, because they can be other diseases that can take the normal bone structure and cause it to become like this, cause osteoporosis to develop. And what are the diseases that can cause bone loss to happen and affect the quality and the quantity of bone? Well, if you're not taking enough calcium and phosphate and vitamin D, then we don't have the minerals necessary to ensure that that bone is mineralizing normally. So patients who may have inadequate calcium and phosphate intake, or may have malabsorption, or may have bowel abnormalities because of inflammatory bowel disease like celiac disease or Crohn's disease, or have had bowel surgery, who have short bowel syndrome, or have had bariatric surgery and have limited bowel capacity to absorb calcium and phosphate and vitamin D, which is necessary to mineralize the bone, those individuals can develop osteoporosis. We can also have osteoporosis develop if we have liver disease, because the liver and the kidney, both liver and kidney disease, cause osteoporosis, because that is where vitamin D is activated. So if you have kidney disease or liver disease, the activation of vitamin D will be impaired. And also what happens with kidney disease is that the phosphate is not being eliminated by the kidney, and that increases amount of PTH released from the parathyroid glands. So as the phosphate is rising, that will increase the release of parathyroid hormone from the parathyroid glands, and excess amounts of parathyroid hormone will cause osteoporosis. If your thyroid gland is overactive, that can cause osteoporosis. If your adrenal glands are overactive, that can cause osteoporosis. And if the male hormone is low testosterone levels, it could be because the pituitary isn't working properly, or the testicular function is affected. That can cause osteoporosis. And in women, the ovaries produce estrogen. And so if estrogen levels are low because of a late menarche or an early menopause, or because of drugs such as long-term use of Depo-Provera, these conditions can result in osteoporosis, because hormonal status is crucial in determining the structure of the skeleton. So the important questions to ask women are: when did your period start? How old were you? Were your periods always regular? Did you have anorexia nervosa? And did you lose your periods for a 6-month time period or longer? And when did menopause occur? And so these are very, very important questions. And in men, we also ask about gonadal status, because we need to know in men, are the male hormones normal? Testosterone in men will be converted to estrogen. And in men also, it's the estrogen levels that are crucial in maintaining bone health. And so the two most important factors, whether you're a younger person or an older person, are your body mass index and your hormonal status, because those two factors are very, very critical in determining the formation of normal bone density and the normal structure of the skeleton, and also maintaining it. So we need to achieve our ideal peak bone density and be able to maintain it. And that will be determined by body mass index and also by gonadal status or hormonal status. What are the testosterone levels doing in men, and what are the estrogen levels doing in women who are still premenopausal under the age of 50? So if a woman experiences an early menopause, if she undergoes menopause at the age of 35 and she develops osteoporosis on that basis, the drug that will be ideal for her is to give back estrogen. And estrogen is the ideal drug for women experiencing an early menopause. Obviously, we need to find out, why did this woman undergo an early menopause? And then we would give back estrogen, because estrogen not only protects the skeleton, but it also is an anabolic agent in that it builds the bone. So the ideal drug for a woman experiencing an early menopause before the age of 50, and the average Canadian age for menopause is 51. So if you have an early menopause, I try and give all those patients estrogen replacement therapy. And in a younger male, we also go with androgen replacement therapy after we find out why the male has low testosterone levels. It could be a pituitary tumor. There could be many, many reasons for it. It could be obesity. It could be alcohol. There could be many reasons. And we need to find out why our patient is hypogonadal or has low estrogen or low testosterone levels. And then we give them back the hormones that are necessary for building and protecting the skeleton. Now, after the age of 50, we know from the Women's Health Initiative that hormone replacement therapy is great for the skeleton, but it has been associated with an increase in the risk of breast cancer, heart disease, and stroke. And so for that reason, we look at other options unless the woman is experiencing intractable menopausal symptoms. If the hot flushes and night sweats are disabling, then we could give back estrogen and it will certainly protect the skeleton. And we could use estrogen up until the age of 60, but after 60 for sure, we're not recommending estrogen replacement therapy, for sure. And we have other medications that we can use that do not have an increase, that are not associated with an increase in the risk of heart disease or stroke or breast cancer, and clearly are very, very beneficial in preserving and protecting the skeleton. And we can also rebuild the skeleton. We have 2 drugs available to us that can rebuild the skeleton. One of them is denosumab, and another one is, so the drugs that will prevent bone loss are the bisphosphonates and denosumab, and the 2 drugs that will rebuild the skeleton are teriparatide, Forteo, and Ramos Salsamat or Evenity. And so those are the 2 bone building drugs that we have available to us. And the drugs that preserve the skeleton are the bisphosphonates, and they are taken orally in the form of risedronate, which is marketed under the name of Actonel, or alendronate, which is marketed under the name of Fosamax or Fosavance. We can give a bisphosphonate intravenously in the form of IV zoledronic acid, and this is marketed under the name of Aclasta. So what these bisphosphonates do is they bind to the skeleton and they will inhibit the osteoclast from removing more bone. So if your bone looks like this, it will preserve it and protect it so that it doesn't get any worse, but they will not rebuild the skeleton. Whereas drugs which can rebuild the skeleton, and we have 2, teriparatide or Forteo is a daily needle, and it can take this bone and make it look like this. In fact, these bone specimens that I'm showing you are bone biopsies taken from a patient who was treated with teriparatide, and this is what she looked like prior to starting therapy, and this is what she looked like after treatment. So teriparatide is a 2-year treatment program, and it can reverse the damage that is seen in a patient who has osteoporosis. So we see reversal of the osteoporotic features. We're seeing thickening of the cortical shell. We're seeing thickening of the trabeculae, and they're reconnecting. So how does this bone know how to reconnect? Well, the bone grows like the stalactites and the stalagmites, and they connect along the lines of gravity. And that's how come this bone, all these holes in the bone are being refilled with a structure that is normal. It's not a chaotic formation of bone. It's forming along the lines of gravity, and it's becoming like normal, healthy bone. And we have another bone builder now called Ramos Salsamat, which is marketed under the name of Evenity. And what that drug will do is it does the work of two drugs. It will work like teriparatide in building new bone and improving the microstructure, but like the anti-resorptive agents, it also protects and preserves the bone. So Ramos Salsamat, over the course of 1 year, will dramatically alter the shape and the structure of the skeleton. So it will improve the microstructural damage, and it will improve the quantity and the quality of the bone that is present. And it's associated with a dramatic decrease in the risk of fracture. So those are the tools that we have available to us. And before we start a patient on treatment, we need to confirm, number one, do they have osteoporosis? And I said that one of the ways that we confirm if they have osteoporosis is by looking at their bone density test. And the bone density test will tell us if they have osteoporosis. And if the femoral neck T-score or the lumbar spine T-score or the total hip T-score or the T-score at the 1/3 radial site at the arm is minus 2.5 or less, then that confirms that the person has osteoporosis if they're postmenopausal or if it's a male if they're over 50. So we can make the diagnosis of osteoporosis on the basis of the bone density test. We can also make the diagnosis of osteoporosis on the basis of a fragility fracture. So if you fall and you break your pelvis with a fall from standing height, that confirms that you have osteoporosis. A pelvic fracture is a fragility fracture. If you fall and you break your hip or your forearm or your humerus or your spine, all of these fractures confirm that you have osteoporosis, and they will increase your risk of fracture. If you have a spine fracture or a hip fracture or more than one fragility fracture, you are automatically in the high fracture risk category. And we don't need a tool to determine what your fracture risk is. That is automatic confirmation that your bone structure is so significantly impaired that A, you have osteoporosis, and B, your fracture risk is high. If you take a vertebrae and you crush it, that is a serious situation. And it also predicts that you're more likely to have further fractures. If you break the strongest bone in your body, which is the hip, that confirms that you have osteoporosis and you have a high fracture risk, regardless of how old you are and regardless of your gender, whether you're a male or a female. It confirms that you have osteoporosis. If you're 35 or 75, if you break your hip with a fall from standing height, you've got osteoporosis. And that confirms it in children as well. Vertebral fractures, hip fractures, or more than one fragility fracture, a long bone fracture, 2 long bone fractures in the upper limbs confirms that you have osteoporosis. And so we need to recognize that there's 2 ways that we diagnose osteoporosis. One is by the presence of a fragility fracture, and the second is by the presence of a low T-score on a bone density test. And each standard deviation reduction is a 10% decrease in your bone density. So if your T-score is minus 2.5, that means that you're 25% less than what your bone density probably was like when you were between the ages of 20 and 29. That's what a T-score is. But you don't need to have both criteria to confirm that you have osteoporosis. Many times I see patients who've had a fragility fracture, they've had a hip fracture, but their spine bone density doesn't look that bad. And the reason for that oftentimes is because if you have arthritis in the spine or calcium deposition in the spine, in the vessels, in the aorta, that overlies the vertebral bodies, that gives a falsely high result. So you have a falsely high bone density test. And if you have arthritis in your hip, that can result in thickening of the femoral neck. We call it buttressing of the femoral neck. It can give you a falsely high result at the hip side as well. And so you could have a falsely elevated bone density test. So the diagnosis of osteoporosis can be made either clinically or by bone density testing. It does not require both. But the important point to remember is that if you've never had a fracture, we can only make the diagnosis by bone density testing if you're over 50, if you're a male, and if you're a post-menopausal female. Then we can make that diagnosis of osteoporosis based on the bone density test. Otherwise, we cannot make the diagnosis of osteoporosis purely on the basis of the bone density test. You need to be older to be able to make the diagnosis of osteoporosis based on the bone density test. So a male over 50 or a postmenopausal female. If you're 40 years old, yes, you can make the diagnosis. If you're a female, 40-year-old postmenopausal female, you can make the diagnosis of osteoporosis based on the bone density test. Now, we need to put all of this information together before we evaluate fracture risk. And we have two tools to evaluate fracture risk. We have the FRAC score that looks at other risk factors. It looks at your age, it looks at your gender, it looks at your weight. As I mentioned, if you're heavier people are less likely to have fragility fractures, and they're also less likely to have osteoporosis. But we do consider weight. We look at prior fracture. If you've had a fracture, that will predict another fracture, and it will increase your risk of fracture. In the immediate 1 to 2 year period, your risk of fracture is very high. After a fragility fracture, it could be as high as 25%. If you have a parent who had a hip fracture, we need to take that into consideration as well. That is associated with an increase in the risk of fracture. If you're a smoker, you're more likely to have a fracture. And we add that information when we calculate your FRAC score. Yes or no, are you a smoker? If you've been on prednisone, that will increase your risk of fracture. Prednisone has multiple harmful effects on the skeleton. It kills off the cells that sense the stress and strain in the microenvironment. Those are the osteocytes. It kills off the cells that lay bone. Those are the osteoblasts. So you could take 7.5 milligrams for prednisone, and in 6 months, you could even have a vertebral fracture, a spine fracture, even before your bone density has gone down. So it's very, very important for your doctor to know if you're on prednisone, because it will have an impact on your fracture risk. Even long-term use of inhaled steroids over a decade will have an impact on your risk of fracture. What about having a condition like rheumatoid arthritis? What happens if you have rheumatoid arthritis is you have an increase in the rate of bone loss because of increases in inflammation. And this is associated, independent of your bone density, with an increase in the risk of fracture. And we believe that there are other diseases that can also increase your risk of fracture in a similar manner, such as long-standing diabetes, such as long-standing chronic kidney disease. But our science is approaching the level at which we will be able to quantify the impact on your fracture risk and be able to include that in the FRAC score calculation. What if you drink alcohol 3 or more a day? That is going to be associated with an increased risk of fracture. Alcohol is toxic to osteoblasts, and alcohol excess is associated with osteoporosis and an increased risk of fracture. In fact, the 3 most common causes of osteoporosis in men are low testosterone, alcohol excess, and prednisone therapy. So when we have a patient with osteoporosis, we evaluate them further. We take a careful history. We look at all of those conditions that I talked about. We look at your medications. We look at alcohol and smoking. And we will then review your height and weight, and we examine patients. We check to make sure that the thyroid gland is not enlarged, because thyroid function can also have an impact. Hyperthyroidism causes bone loss. Oftentimes when I'm examining patients, I'll identify thyroid nodules, and some of these turn out to be cancer. So it is important to do a full examination. And I also listen to the heart and the lungs and check the abdomen, and I will look at the spine. Why am I looking at the spine? I'm looking and I'm pressing on the spine to see if there's areas of tenderness. The reason why I do that is because if a vertebrae has a disease, it could be cancer in the bone, or it could be infection in the bone, or it could be a fracture in the skeleton. When I press on the bone, if there's tenderness, I need to know why there's tenderness. And I will do spinal x-rays. And we also look to see how much space there is between the ribs and the pelvic rim. As the vertebrae start to crush downwards, that individual will start to lose height, and they will develop what we call a dowager's hump. So if you've lost height, you need to tell your doctor that, because they need to do spinal x-rays to see if you've had compression fractures develop in the spine. And there was one study showing that all people who have had height loss, if you do spinal x-rays, 2/3 of them will have had the height loss because of degenerative changes. That means the intervertebral discs are shrinking, and that is the reason why they are developing height loss. But 1/3 of those people had silent vertebral fractures. So if you've lost height, then you need to talk to your doctor and consider having spinal x-rays done to find out if you've had a fracture in the spine. Then if we find a fracture, we need to know, why did this fracture happen? Is it just because of the osteoporosis, or could it be cancer that's in the bone? Or is there something else going on? Is this a pathologic fracture? And we need to do an MRI or a CT scan to find out why. Sometimes we need to do those additional imaging based on the radiographic appearance, based on what the spinal x-rays look like, and the age of the patient, and all the factors that we put together. We decide, do we need to do a CAT scan or an MRI? Or is this just an osteoporotic fracture? And it's not just an osteoporotic fracture, it's an important fracture because it will have an impact on mortality and what we call morbidity. And so if you have someone who has a hip fracture, this will be associated with an increased risk of death. There's about a 1 in 5 mortality rate after a hip fracture, and that happens in the first year after the hip fracture. Well, if you look at vertebral fractures, 5 years out, we have a similar mortality after vertebral fractures. So it's important for us to identify these fractures, vertebral fractures in particular, because 2/3 of vertebral fractures are actually silent. And when we measure height in our clinic, oftentimes patients are surprised. And I'll tell them, you're 5'1", and they'll say, what? I used to be 5'4". And so we are obviously going to do spinal x-rays to see, where did those 3 inches go? Were they because of the disc shrinking that we've lost that height, or did the vertebral body actually crush downwards? And if the vertebral body crushed downwards, why did it crush downwards? Is it because of osteoporosis, or is there something else going on in the skeleton? And some of the blood tests that we do, we also make sure that our patients don't have myeloma, which is a tumor in the bone marrow. And we always make sure that we've evaluated thyroid function, calcium, phosphorus, we check magnesium, we check vitamin D, we check parathyroid hormone levels, we check kidney function, because some drugs are cleared through the kidney, such as the bisphosphonates. So alendronate, risedronate, zeledronate, these drugs, half of them get into the bone, whether we take it orally or we take it intravenously. Half of it is deposited into the skeleton, and the other half is cleared through the kidney. So if the kidney function is impaired, that will affect how much of that drug is being eliminated through the kidney. And we don't use those drugs if the kidney function is lower than 35 mils per minute. We can use denosumab all the way down to kidney function levels of 15 mils per minute, because denosumab is an antibody and it's given subcutaneously twice a year, and it can be given to people who have impaired kidney function. And we can go down to a GFR of 15 mils per minute with denosumab. With teriparatide, we need to look at kidney function closely, because as kidney function goes down, it results in elevations in the parathyroid hormone. And if the patient already has a high PTH, we can't give teriparatide. So we need to look at all the blood tests, we look at spinal x-rays, we look at the bone density test, and we put all this information together and decide, number one, does our patient have osteoporosis? Number two, what is our patient's fracture risk? Number three, what are the blood tests like? Are our patients getting enough calcium? Are they getting enough vitamin D? Do they have other hormonal abnormalities that need to be corrected before we can give them a medication for their osteoporosis? And number four, do they need another drug? And number five, which drug is best for our patient? So we don't just pick a drug out of the hat. We have to go through all these steps and then decide which drug is best for our patient. And I just wanted to say that after a fracture, the risk of another fracture is very, very high. It's approximately 12% risk of having another hip fracture after you've had a hip fracture. And this is why it's very, very important that you be started on treatment. And everyday patients tell me, oh, I don't want to go on osteoporosis therapy. You know, I think I had that fracture. If anybody fell the way I fell, they would have broken a bone. And I tell them, well, you know, you were skating, you fell on ice and you broke your hip. How many other people were skating and fell on ice and broke their hip and had to be taken off the rink by ambulance? You know, that doesn't happen. So if you fall from standing height and you break something, that confirms that your bone structure is not normal, and you need to be evaluated and you need to be treated. And it shouldn't happen 10 years from the time that you had the fracture. You need to be treated right away, because look, your risk of having another fracture is highest in the first 2 years after that fracture. And if we don't treat you right away, and we say, oh, here, Mrs. Jones, we'll fix your hip and we'll let you go, you'll just come right back in with another hip fracture. And there's a mortality associated with these fractures. You may not make it after the hip fracture, because a hip fracture requires major surgery and prolonged bed rest and a rehabilitation program to recover from that situation. And Kerry's telling me that I have 8 minutes left, so I'm going to wrap up and just make some concluding comments. But it is absolutely crucial that we treat our patients aggressively if they've had a major osteoporotic fracture and if they have a high fracture risk. So what is a high fracture risk? A high fracture risk means, if you look at the Carrot curve, if you can see this, if you look at this, it means that you fall in the red zone. You have a fracture risk that is more than 20% over the next 10 years. That means your risk of fracture, you have a risk of 1 in 5. If you're concerned about potential side effects of therapy, what is your risk of osteonecrosis of the jaw? Which means that you might, if your dentist pulls out a tooth and if you've been on osteoporosis therapy, the bone may not heal as quickly after having a dental extraction if you've been on osteoporosis therapy, such as a bisphosphonate or denosumab. What is the risk of the bone becoming infected? It's 1 in 100,000. And it's really no different to the general population. What is the risk of you having a fracture if your risk is more than the 20% in the next 10 years? It's 1 in 5. So you have to balance that risk. Your risk of having another fracture is 1 in 5. And if it's a hip fracture, you might die 24%. Your risk of developing osteonecrosis of the jaw is 1 in 100,000. Obviously, the benefit of therapy is far, far greater than your potential risk. And we developed ONJ guidelines which are posted on Osteoporosis Canada's website. And we have a strategy to reduce your risk of developing ONJ anyway. What is your risk of developing an atypical femoral fracture? Well, if you're on osteoporosis therapy, and you've taken it for 10 years, with bisphosphonates, it's 1 in 1,000. With denosumab, it could be 1 in 3,000. You might develop an atypical femoral fracture without being on any treatment, but your risk of an osteoporotic fracture is 1 in 5. So your treatment is going to have a far greater benefit than the potential side effects. And your doctor will balance those risks and benefits and talk to you about how we can reduce that risk of a potential side effect and offer you the best treatment for your fracture risk and for your particular condition. So I'd like to conclude by saying that we need to treat osteoporosis, especially people who've had a prior fracture. These people must be treated because they're going to go on to develop more fractures. And I'd like to say a few words about vitamin D before I conclude. And what we found is that countries where low levels of vitamin D are more common are also more likely to have a higher rate of COVID and have higher severity of COVID infections. And we don't have the full proof that vitamin D can protect us from COVID infections and have an impact on the severity of COVID, but we do understand that vitamin D has an important role to play in the immune response. And everybody who has osteoporosis needs to make sure that our vitamin D levels are normal, and normal is 75 to 125 nanomoles per liter. But to ensure that we have the right level of vitamin D is important for bone health, and it may also be of value in ensuring that our immune response is working at optimal capacity to ensure that we're not developing, we're not increasing our risk of COVID because of vitamin D insufficiency. Obviously, we have to follow the appropriate social distancing and masking and washing our hands, but also ensuring that we're taking adequate vitamin D is important. I also want to say one last point before I conclude, and that is that it is absolutely crucial that we not miss our medication, especially during a pandemic. If we skip our dose of denosumab and not take it when it's due, then the rate of bone loss will rise and we could have a fracture in the spine and end up in hospital with a vertebral fracture. And the worst place to be in a pandemic is being in close association with other people, where you may increase your risk of developing COVID-19. You don't want to increase your risk of developing COVID-19 because of an intercurrent illness that requires you to now expose yourself to other health professionals. Even though we're gloved and masked and taking precaution, it's best to not increase your exposure to situations where you're more likely to develop COVID-19. So if you want to stay out of hospital, please ensure that you're not missing your medication, because if you don't take your medication, then you cannot reduce your risk of fracture, because the medicine can't help us if we don't take it. So compliance with therapy is crucial. Being physically active is crucial. Even though we're at home in isolation, we must ensure that we're physically active. And I tell my patients to walk every day, try and get to 5K every day, try and do as much as you physically can, avoid forward bending, avoid heavy lifting, and do your walking. And be positive. And if you have any questions, connect with your doctors. And your doctor can contact you by phone or by email, via the OTN health network. Your physician is there for you and you're not isolated. So with that, I'd like to thank you for your attention and answer any questions that you may have. So back to you, Kerry.
Thank you, Aliya. That was absolutely wonderful. We have some questions that I'm going to pass on to you and let you answer them. The first question I think you may have answered, but I think it's timely. Someone wants to know, do regularly scheduled appointments from the past still take place during the pandemic?
Yes, so doctors are still connecting with patients, and we're making phone calls, and we're contacting patients with the OTN Health Network. We can actually do a Skype call. So it's absolutely essential to continue your treatment. You can do blood tests. You can go to the lab and confirm what time you should be at the lab so that you're not sitting in contact with other people. Wear a mask when you go outside your home. It's very, very important that everybody wear a mask. It's absolutely crucial. You don't necessarily need to do your bone density. The bone density can wait. Your doctor can evaluate your fracture risk without the bone density. But you need to have the blood tests. The blood tests are crucial. If your vitamin D levels are low, then their medications cannot be given until the vitamin D levels are normal. Because if the vitamin D is low, then the medication keeps the calcium in the skeleton. And if you don't have enough vitamin D, then you can't absorb the calcium from the bowel, and your calcium level may go down. And then because the drug is keeping that calcium in the skeleton isn't releasing calcium. So the blood calcium can go down, and you could have a seizure. You could end up going to hospital with a seizure. So I tell my patients it's absolutely crucial to make sure you're getting enough vitamin D. We're telling our patients to get calcium preferentially from food and not take calcium supplements. That means 3 to 4 servings of dairy a day. But if you can't get the calcium from food, then you have to take calcium supplements. But talk to your doctor, and your doctor will be able to tell you that the lab tests are absolutely crucial for treatment, and you can get the blood work done at the lab. And if you can't get out to the lab can come to you. Contact the lab and say, can someone come to my home and do the blood test for me, because I can't get out. And that's what I recommend for patients who are having difficulty with mobility. But be careful, do the social distancing, always wear a mask, wash your hands, try and ensure that we're reducing our risk of COVID-19.
Thanks, Aliya. The next question is, how long can you take a bisphosphonate without a drug holiday?
And that's a very good question, Kerry. And we recognize that the bisphosphonate accumulates in the skeleton. And that's what bisphosphonates do. So that's the reason why we give the drug holiday, because after 5 years, you have enough bisphosphonate in your skeleton that it will continue to be slowly released, and it will continue to inhibit the osteoclasts that are going to remove the bone. And so we recommend that you can take a bisphosphonate up to 5 years. Now, at the 5-year mark, we need to evaluate fracture risk. If the fracture risk is low, stop that medicine. If the fracture risk is moderate, it's in the 10 to 20% range, and you have never had a fragility fracture, and at the femoral neck, the T-score is better than -2.5, then you can stop that bisphosphonate and go on what we call a drug holiday. And a drug holiday means that you've stopped your bisphosphonate. The only drugs that you can go on a drug holiday on are bisphosphonates. So that's risedronate or Actonel, alendronate or Fosamax, and IV zoledronic acid. Now we only use that one dose will actually protect you for 5 years with the IV zoledronic acid. And so these drugs have long-term skeletal retention and long-term skeletal protection. And so you can stop the drug at the 5-year mark and still have ongoing protection. Now, if you've had a prior fragility fracture or your fracture risk is high, then you need to continue drug therapy. And the long-term data with the bisphosphonates has shown us that bisphosphonates can reduce the risk of vertebral fracture if you continue to use them. But when you continue to use them, the risk of these atypical femoral fractures rises. And so what I do after 5 years of bisphosphonate therapy is I will switch to another molecule. I may switch to denosumab, I may switch to teriparatide or Ramos Salsamat, or I may use denosumab with teriparatide together. So that's what I do for high fracture risk patients. If my patient has a high fracture risk, I would start off with a drug that is more potent than the bisphosphonate, such as you could start with teriparatide or Ramos Salsamat. And if your patient can't take either of those, then you could go to denosumab. That's all of those three classes are very, very good for high fracture risk. And if those are not possible, then you could give a bisphosphonate as well. And when your patient is on a drug holiday, then we monitor those patients. We do the bone density every 2 years. We ask them, have you broken a bone? If they haven't broken any bones and the bone density is stable, I continue that drug holiday. And some of my patients have been on a drug holiday for 10 years. So we don't necessarily need to stop the drug holiday at 5 years. The clinical research trials showed us that our patients could be on the drug holiday for 5 years, but with our own clinical experience, we've seen that the drug holiday can be extended out for longer than 5 years.
Thank you, Aliya. Along the same line, this person is asking, is body size considered in the dosage of medications, or is a small person treated with the same dosage as a larger one?
And that's a very good question. And in the clinical research, we're guided by evidence. And so in the clinical research trials, patients of all sizes and shapes were enrolled in the studies. And what we found were the doses that we're using are the optimal doses for fracture risk reduction. And in the clinical trials, we've also used lower doses and higher doses have been used in the dose finding studies. So dose finding studies are done before the clinical trial happens, and the dose finding studies are done to find out which dose is ideal. And in the dose finding studies, that's where these doses were confirmed. And the dose finding studies are very helpful in identifying what is the optimal dose for a patient. But we use these doses because they have been proven in the clinical research trials to be optimal and beneficial. And we don't modify them based on your weight or your height. Some parts of the world, they have preferred to use lower doses, such as in Asia. And they have done research with lower doses. There is, for example, a low dose teriparatide study showing us that low doses have been shown to be effective in preventing fractures. So we could certainly look at that, but right now the doses that we're using are the doses that were determined to be optimal in the dose finding studies. Mm-hmm.
Thank you, Dr. Khan. This person is asking, are there any foods that you should be avoiding with osteoporosis that could be corrosive?
So we recommend that patients follow the Canada Food Guide, and the foods that can be harmful. Coffee in excess can be harmful. So 4 cups or more can be harmful. Tea is beneficial. So if you're a heavy coffee drinker, I recommend switching to tea. And follow the Canada Food Guide. You want to be eating a balanced food plan, so if you're getting adequate fruits and vegetables, adequate protein is good. A high salt, high protein diet can cause us to lose calcium through the kidney. So cutting back on salt is good. You don't want to have too much protein, but you don't want to have inadequate protein as well. So the Canada Food Guide is ideal, and ensure that we're getting adequate calcium from food sources. Dairy products are of value, and the fermented dairy products have been shown to have an impact on the gut microbiome and may also be able to lower inflammation, because the gut microbiome interacts with our body and interacts with our organ systems. And there is an interaction in the inflammatory markers, actually, And so fermented dairy products are best. So I ask my patients to take fermented dairy products. That would be yogurt, kefir, cheese, but cheese will have an impact on your lipid profile. So yogurt is really ideal and kefir is ideal. Fermented dairy products are very, very valuable source of calcium.
Okay, thank you. This will be the last question. Unfortunately, we're running out of time. This person is asking about calcium supplements and strontium working together. Can they be used as an alternative to estrogen replacement?
Right. And so strontium is a herbal supplement, has not been evaluated in clinical research trials. Strontium ranelate is a drug that was evaluated and was never approved in Canada, but strontium ranelate was discontinued because of an increased risk of death with cardiovascular events and also skin desquamation. The herbal strontium has not been evaluated, and I don't recommend that. It is not an approved product. We don't know if it has an impact on the skeleton in terms of fracture risk reduction. Calcium by itself is not going to prevent fractures. And I tell my patients, it's like, you know, if your plant isn't growing, just pouring tons and tons of water on it is not going to help it to grow. So if there's a problem with the skeleton, and if the skeleton structure is altered and we have impaired quantity and quality of bone, then just taking extra calcium isn't going to help you. All that extra calcium that you're taking has to be absorbed. It enters our bloodstream, and now the kidneys have to get rid of that extra calcium. Because if the kidneys don't get rid of the extra calcium, the high serum calcium will then have an impact on our kidney function, and it prevents our kidney from being able to concentrate the urine. And patients who have a high calcium become dehydrated, and you will die from hypercalcemia. So to prevent the death from happening, the kidneys have to pump out all this excess calcium, and you're going to get a kidney stone. So do your body a favor and don't take too much calcium. It's a fallacy to think I'll just take tons of calcium and get my bones to grow. If it was that simple, we wouldn't be spending billions of dollars on scientific research trying to understand how the bone cells work, how does the microstructure have an impact on fracture, how can we intervene pharmacologically in bone biology and improve the structure of the skeleton. Similarly, too much vitamin D is harmful as well. If you take too much vitamin D, then that will increase the absorption of calcium. It can cause high blood calcium, and high serum calcium, it damages kidney function. In fact, I was asked to see a patient who had chronic kidney disease because they were taking too much vitamin D. So it causes kidney stones, it will cause chronic kidney disease, and too much vitamin D actually causes bone resorption because it increases rank ligand expression, which is a signaling protein from the osteoblast, which increases osteoclast activity. So trust your doctor and don't be your own doctor. You know, I tell my patients, my patients will say, okay, well, this is what you're telling me, but you know what, I'll do my own research and I'll figure out myself what to take. And I tell them, hey, I'm not a lawyer. If I need a lawyer, I go to see a lawyer. I don't become a lawyer all of a sudden. I'm not an engineer. I'm not going to build my own house and just do it from Google. I'd be foolish if I did that. So we shouldn't become our own doctor. There's a reason why we have to go to medical school for 4 years and do residency for 5 years and a fellowship for another 1 to 2 years and then gain experience treating patients with bone disease. You can't get that from Googling. Just like I'm not going to build a house and pretend that I'm an engineer just because I Googled how to build a house. So we don't want to do ourselves a disfavor and be our own doctor when we're not doctors. So we should trust our doctor. There's a reason why they have a license to practice medicine, and we should ask our doctor to advise us. It's always good to be a knowledgeable patient, because when you're knowledgeable, you can ask your doctor more questions And you need to work with your doctor as a team, but trust your doctor. If you don't trust your doctor, then don't see that doctor. See a doctor that you can trust.
Wow. Well, thank you, Dr. Khan, for an informative presentation and for answering so many questions. And thank you also to all of you for joining us today. Visit Osteoporosis Canada's website for more information on osteoporosis drug treatments and medications at osteoporosis.ca/treatment. You can also view the recorded version of this webinar on the OC Replay webpage at osteoporosis.ca/OC-replay. An email with the replay version of this webinar will be sent out within the next few days to attendees. Until next time, thank you again, Dr. Khan, and thank you, and continue to stay connected and stay informed. Have a great day, everyone.
Thank you.